As surgeons, we think we're kind of cool. This is Nikos and I doing a robotic transplant, and we like to think it's a complex, difficult kind of thing to do. But sometimes the nephrologists will come down to theatre to show us how it's done. This is Yelena making sure that we're doing a transplant properly. And if there's one thing that surgeons really don't like is when nephrologists call us plumbers and say, just plumb the kidney in, would you? But actually this talk is all about plumbing. It's all about how we fit transplants in when there's nowhere to plumb them into. You may think this is a surgical talk, and it will be hopefully of interest for the surgeons, but hopefully it'll be of interest to all of you, because you'll all be dealing with children like this. And just as we were talking this morning about how to decide whether or not we should be treating patients with certain conditions, I think it's quite important to be thinking about whether someone's suitable for consideration for a transplant. So in terms of complexity in transplantation, you've heard from Nikos about antibody incompatibility, metabolic abnormalities such as MMA, there are many others, cardiac or respiratory issues which often form part of the congenital syndromes that have caused the renal failure. You've heard this morning about congenital abnormalities of the urinary tract and kidneys, and I'm going to focus on vascular anomalies. So in this centre we tend to put the kidney onto the aorta and the IVC for the small children, for children under 20 kilos. For children over 20 kilos, we tend to take a retroperitoneal approach and put them onto the iliac vessels. Other centres will have slightly different approaches, but clearly there's a problem if there's no aorta or IVC, since you've either got nothing to put the kidney onto, or you've got no drainage of the venous system or no arterial inflow. And here's an example, I'm going to show you more detail later on, of someone who's got no inferior vena cava and all the blood supply from the lower limbs is draining up through that venous collateral. And here's someone with no aorta, where the aorta peters out. So why do children have vascular anomalies? Well, central lines are one of the commonest reasons, central lines which then take out the inferior vena cava. And one of the key messages of this talk for nephrologists, intensivists and so on is please try and save those veins. So you put in a femoral line to a small child, you're going to have a catheter in the IVC. If you leave it there for any length of time, the IVC will be gone, and that's going to make transplantation difficult or impossible. Previous surgery, which may be vascular surgery or other types of surgery, various syndromes which are characterized by hypercoagulability, and congenital disease, and the most common one that we come across is mid-aortic syndrome, where the aorta just peters out. It's characterized by hypertension, absent distant pulses, and an aortogram similar to that. So I'm going to give you a few examples of some of these situations and how people might approach them, and hopefully what we'll do at the end of this talk is have a bit of a discussion, if there's time, on different approaches, because there's no right or wrong approach. So 15-year-old boy, again with no inferior vena cava, this is the aorta, this is another big collateral going up from the iliac system, and what we did here was made a left iliac fossa incision, went on to that iliac vein, and there were some difficulties in that there was a bit of thrombus there which responded to treatment with some heparin, but ultimately that child did okay. Here's another one, 7-year-old, both kidneys gone, previous transplant at the age of 3 onto the cava, which thrombosed, recurrent line thrombosis, SVC thrombosis, and no inferior vena cava. So clearly she's in a difficult situation if we try and continue with dialysis for any length of time. And what we did here was we made a midline incision. Obviously there were dense adhesions from the previous surgery, but as is often the case in our experience, you can find a small segment of suprarenal cava. you can find a small segment of suprarenal cava and use that as a landing site. And we used perioperative heparin, and I think if you are using venous collaterals or if there's any doubt about the venous outflow, then being a bit aggressive with the heparin certainly is worthwhile. So there are a variety of different options in summary. If there's no IVC, we can consider the collateral veins, and sometimes people will measure the pressures in those collateral veins to determine whether or not there's enough outflow. We can look, as I've said, for a suprarenal IVC. We can mobilize the liver, and we can use the retrohepatic IVC or the right hepatic vein, or in this scenario, they've used a bit of deceased donor vein to make a conduit up to that cava. Or you can use the mesenteric veins. We've never done that, but it's certainly reported. Another thing that we have done, this isn't our paper, but you can use the portal vein. We've done that twice, and one of them didn't do too well. One of them did okay. The portal vein's going to be pretty small, and I'm not sure that in a small child it's going to be good enough for outflow, but some people have had success with this. And of course, you could just take the native kidney out and put the new kidney in, but that kind of begs the question, well, if there's venous outflow at this level, why not just put the new kidney onto the cava at this level with adequate exposure? So in summary, if there's no IVC, then it may be worth exploring to see what vein you can find. And in that scenario, you may think about starting the recipient prior to the donor, and that's something that we commonly do. And since we do the donors in this hospital, and we do the recipients in one of the two children's hospitals, has significant logistical implications. So if we're starting the recipient, what we tend to do is have the donor down in the anaesthetic room, and we've prepared in advance, both prepared the donor and the theatre team, that the donor's going to be waiting in that room for quite some time, maybe an hour. Someone has to stay with them. And then when we give the go-ahead, the donor surgeon and their team needs to move quite quickly. And that means having two experienced surgeons with the recipient, because we tend to do these complex cases with two consultants, but also an experienced surgeon with the donor. Because what you don't want is someone who's fairly early on in their consultant career being told, right, we've got a child on the table, we're waiting for the kidney, get it out quickly, because that just puts too much pressure on them. So that's the cava. What if there's no aorta? So here's a 9-year-old girl with mid-aortic syndrome who's actually had a graft, and you can see the top half of the graft here and the bottom half of the graft here. To get round that problem in the mid-aorta, father wants to donate, so we do a midline incision. We have a look at the vessels, and here we went on to the common iliac artery, which on the angiogram looks pretty thin and unappealing. But when we went in, it looked okay, and we transplanted there rather than onto the graft. Here's another one with quite a number of congenital abnormalities, and she's had an aortic graft, an aortic arch graft twice. She's had a lot of surgery on her urinary tract, and her aorta peters out here, and her mother wanted to donate to her. So what we did was we got a piece of deceased donor iliac artery from the liver team. So the liver team will store these vessels for use in liver transplantation, and we asked them for a piece of deceased donor artery as a conduit, and we went very, very high. So we split the diaphragm and went up above the celiac artery. So this is her native kidney, and this is her transplant kidney. So normally the transplant kidney is here. It's actually above the native kidney, and this is this conduit going high up onto the aorta. And what's interesting about this is that you now have two different tissue types. You've got the kidney and you've got the conduit that we've used. And what we found was that she actually seemed to develop some donor-specific antibody to the conduit and not to the kidney. And that was accompanied with both a rise in creatinine and a stenosis of the conduit. And our first thought was that the stenosis was just where we joined the vessels together, and the join was just too small. We stretched it up. The DSA had gone up. We increased the immunosuppression. The DSA went down. The creatinine came down. And since then, she's been absolutely fine. She's now just finishing her university degree. This is another case with no aorta and no IVC. And she'd had an aortic graft, a long aortic graft, an SVC obstruction, multiple abdominal trauma. Her donor was blood group incompatible, and she was highly sensitized, just to make matters even more complicated. And this is her angiogram, so it's the same aortic angiogram. This is the graft here. And this is the venogram, which you saw earlier on, so no IVC. So in this scenario, we had multiple multidisciplinary meetings. And as Joe was saying earlier on this morning, we used the hospital ethics team. We talked to the palliative care team and decided eventually as a group that it would be worth going ahead with this, and talked to the mother about palliative care, withdrawal of dialysis, because clearly access was increasingly problematic. But the decision was made to go ahead. We had two consultants at surgery, and we started the recipient first and managed to get it onto the distal aorta just below the graft and onto that gonadal vein. And the kidney survived. Unfortunately, the child did not. She went back to her home country and died about 3 months after transplant from infection. So we've tried to characterize some of these anomalies in this paper, and you haven't got copies of these slide presentations yet, but we have printed out some, so they will be distributed. So this paper describes a means of characterizing the different levels of occlusion in the aorta or the IVC, which we hope would be useful for discussion. One of the other things we've started doing, which I'm sure many of you are aware of, is 3D printing. So we wanted to put his kidney, and he's a bit taller than me, into Lucy, who was pretty small at the time. And the question is, okay, is it all going to fit? And the answer is yes, it probably will fit. We've never had a case since I've been here where we've found we couldn't actually do the case on the day. But the question is, how easy is the case going to be? And will we need a mesh? Will we need other strategies? Where we've got complex vascular anatomy, how is it all going to work? So what we do is we 3D print, and we take the donor CT scan and print the kidney. And if you can just move your mouse to there, click the arrow, yeah. And this is the printer in action. So this just prints over the weekend. We switch it on Friday and leave it for a couple of days. As you can see, nothing much happens, so it takes a long time to lay it down. And then we can also print the recipient anatomy. And we started off by printing the vessels. And this was the case I showed you with the aortic graft. And we looked at where we could try and get the artery onto. But we can also print the abdominal wall. And those of you who've looked have probably seen over in the corner, we've got a series of prints, from some of them from some of your centres, to try and help plan surgery. And we can print the liver, we can print the bones, and we can actually do the bones of different consistency to the liver. Could you just click on that one as well? And we've done it. This is me trying to fit the kidney in and thinking, yeah, that's not going to work, is it? Just prior to an operation. And then we can correlate this with what we actually see at surgery. And the correlation seems to be pretty good. Here's a case where Imran, who you heard from this morning, the urologist, was involved. So he took these kidneys out in a young child, 2-year-old. There were multiple aneurysms. And then we went in and did a living donor transplant. And here's one where, when we looked at this angiogram, the feeling of the MDM was that we shouldn't go ahead with transplantation at the moment because there was a high division of the aorta which seemed to have a funny configuration. When we printed it and passed it around, we decided it would be reasonable to go ahead, which we then did, and the outcome was good. So, in summary, I think it's important that there is a multidisciplinary discussion. Sometimes we have to involve our vascular colleagues, our urological colleagues, as well obviously as our nephrological colleagues, and sometimes even a liver surgeon, although we try and avoid those if we can. 2 consultant surgeons in theatre for any complex case, and very common for us to do simultaneous surgery or to start the recipient first, and that needs a lot of coordination and thinking about how you manage the donor side of things. We want to avoid deceased-donation if possible, so these complex cases we don't want to be doing at 3 o'clock in the morning on a bank holiday weekend when no one's around and someone's struggling on. But if we have to list them for deceased-donation, then we'll give consideration. They're going to be in theatre for a long time. They're going to need to go to intensive care afterwards, and we've got to prepare for that. And very often when you inspect the vessels, something that doesn't look doable angiographically is feasible. So it's always worth thinking about having a look-see if there's doubt. The use of a conduit is worth thinking about, but if you've got a conduit in, always remember that you may get rejection of that conduit, even though the creatinine is more or less okay and the kidney's not undergoing any rejection. And 3D printing can help you in some cases. Lastly, as I said earlier on, try and preserve not just the peripheral veins, but the IVC, because that's really critical when they come on to transplantation. That's it. Thank you.
Thank you, Nizam, for that overview. Any questions from the audience? Yes, all the surgeons. I'll just walk this way first, over, and then I'll come to you.
Thanks, Nizam. That's a fantastic talk. Just regarding the conduit, when you transplanted and used that, did you tissue type the conduit to make sure it was compatible, or did you just blood group match it and hope for the best?
We didn't do any of those things. So we got hold of the type. So we knew what the type was for future reference because we were aware that this could actually happen, but we didn't try and select one that was appropriate. We just use it.
Well, actually, he's asked me the same question I was going to ask, so I'll have to think of something else. But you showed about where the aorta was absent, and you went on to prosthetic graft. Do you have a preference for which graft, or do you leave that to the discrimination of the vascular surgeons?
Yeah, so where they're doing a replacement graft of an aortic segment, that'll be the vascular surgeons who do that, and that's up to them. Nikos was involved in an auto transplant with the vascular surgeons last week. And what did they use then? They used Dacron. So you could use Dacron, you could use Gore-Tex.
Sorry, just one more question. You mentioned about the absent IVC or occluded IVC, about venous pressures. Is that part of your routine practice to measure?
No, we haven't made too much of that, really. I think it's quite difficult. If you've got something like that collateral vein that I showed you, the gonadal vein, you can try and get the pressures, but it's going to be quite difficult to get decent pressures. And very often, when we've measured pressures, we've then been a bit puzzled with the results. You think, well, what does that mean? Is there really it never seems to be very clear cut. So we've kind of gone off that.
Thank you.
One last question from Second to last question then from Aldo first.
First of all, great work. In our practice, we use, for all this replacement, pediatric kidneys. And we have been able to use very marginal veins, the drainage, but also the pediatric kidney conditions to the lower flow, and the venous drainage improves with time. Number two, one of the other ones that we have used have been the splenic vein, and the next one that we have ready is the left hepatic veins for this, but great work.
Yeah, no, good point. Yeah, splenic veins certainly, yeah, and the hepatic veins, yeah. Yeah, I mean, these have been, they've all been adult kidneys because most of them have been living donors.
Thanks very much. Great talk. I was interested in one of the cases where you talked about perioperative low molecular weight heparin because you'd noticed there was sort of low venous outflow. Do you have a sort of tips or strategies as to your perioperative anticoagulation regimes and what drives it?
So normally we're just using aspirin for our standard cases. If we thought there was some concern about venous outflow, so if I were transplanting into that gonadal vein, then I'd be as aggressive as I could be with heparin. We try not to give full IV, full dose heparin because we're going to be taking them back to theatre if we do that. So if we can avoid that, we will. But if it's really marginal, then we do that. But certainly prophylactic dose heparin in any situation where there's concern. Yeah.
Hi, I'm Claire. I'm one of the renal coordinators from St James's in Leeds. In terms of the donor vessels, we've certainly had planned live donor cases where we knew that we would very likely need additional vessels. So what we've actually done is we've done a 2-week kind of scouting programme before the date of the planned donation. So what we've done now, we've done this at least 3 times in the Yorkshire region, and for the first week we will work locally, so certainly staying within the Yorkshire region, specifically looking for blood group and HLA matched vessels in advance. So each donor that is within the age set criteria, we will, our H&I lab, which will be typing their donor anyway, will match them against our child so that we will, in theory, have donor matched vessels if we need them. If we're not successful at the end of the first week, that then goes out as a national appeal to all of the SNOD teams. And it's a much wider approach, but what we will do is we will spend those 2 weeks actively trying to find matched vessels. And on 2 of those occasions, we certainly had well-matched vessels. On the 3rd occasion, what we needed to do was actually revert just back to the liver fridge and find something that was marginally matched and perhaps a little bit outside the age criteria. But we've also used Speak Tissue Bank as well. And it's been as simple as we've provided a sketch of what we've wanted in essentially a Y connector. And they've had a look through their vessels, and with a couple of weeks' notice, they will try and harvest a set of vessels for us that we will be able to use, and then HLI ABO doesn't come into it because the vessels are just coming straight out of the tissue bank. So that's been really useful for us.
That's a really useful suggestion. Yeah, and I think I think good coordination with the local liver team, and if you're co-located with a liver team, then that's easier. But widening it out nationally, certainly, yeah, it's a good idea.